नाशनाय त्रैलोक्यनाथाय Shri Mahavishnave Namaha. It gives me immense pleasure to extend you a very warm welcome on behalf of SVAK and Shri Paripurna Sanatana Ayurvedic Medical College, Bangalore. Myself, Aarti Chande, I am pursuing my PG from Kaya Chikitsa Department of Munyal College, Manipal. Firstly, I will brief you about the SVAK and Dhanvantari Vedike. SVAK is Swadeshi Vigyana Andolana Karnataka and is a vibrant non-profit science movement. Through the Dhanvantari Vedike, they are conducting the series of webinars. So today by this virtual meet, we will perceive the traditional system of Ayurveda in a very holistic way, by which it will reach to the community on a global terms. As it is told in our Ayurvedic Shastras that Tadvidya Sambhasha Buddhivardhananam Shrestha and Vaidya Samuha Nishanshaya Karanam, discussion and gatherings help us to evolve in a better way. With this motive, let's begin this virtual conference. Now I call upon Dr. Viraya Swami, Professor and Principal in Department of Dravya Guna from Sri Paripurna Sanatana Ayurveda Medical College to address the gathering. Sir.
I express a very good evening to all dignitaries. Very first of all, I would like to thank and welcome Dr. Rajneesh Vigri, who is a well-known teacher. He is one of the beloved teacher of so many students. Right now, sir is working as a professor in HOD for the Department of Shalya Tantra in SDM College of Ayurveda, Udupi. Sir, he has been a mentor for so many students and he has guided so many PG scholars as well. And he has his own technology or some inventions, especially in case of rectal diseases. So, in spite of his busy schedule, he has made some time for us. And behalf of all the audience, behalf of all the organizations like Swadeshi Vijnana Andolan, Dhanvantari Vedike, Paripurna Sanatana College, as well as Munyal Ayurveda College, I welcome Dr. Rajneesh Vigiri. Please welcome, sir.
Thank you, sir. Now straightly we will start today's session. First of all, I will introduce Dr. Rajneesh Giri, sir. He has completed his graduation in 1997 and post-graduation in Shalya Department in 2000 from Government Ayurveda Medical College, Bangalore. He has completed his PhD from Institute of Medical Sciences, BHU Varanasi in 2004. He has 6 publications under his name under Chaukhamba Pragashan and Guguluk Shara Sutra in Fistula in Eno in Ayurmedline. He has been honored by Fellow of International Council of Ayurveda USA. He has received led Ram Avatar Pandey Memorial Award for Best Paper Presentation in 6th National Conference and 1st International Congress of Association of Anesthetists of Indian Medicine in 2003. He has been guest speaker at National Conference in BHU, Ayur Sutra at Tamil Nadu, Kshara Sutra Training Program in SDM Hassan, Shri Shri College of Ayurveda Bangalore, Divisional Level of Kshara Sutra Campaign in Hubli, State Level Kshara Sutra Campaign at R.A. Podar College, Maharashtra, National Level Kshara Sutra Campaign at AIIMS, New Delhi. He has done paper presentation in various national conference at Jammu, Bangalore, BHU Varanasi, Sushruta Association Pune, New Delhi and NIA Jaipur. He has attended National Congress on Updated Proctology 2011, Navi Mumbai and training program of Kshara Sutra Therapy at BHU. He is approved guide to postgraduate student of Shalya Tantra by RGHS. Examiner to BMS and MS course in Shalya Tantra department. He has worked as Kshara Sutra consultant for Anorectal Clinic of Arya Vaidya Pharmacy Hospital, Coimbatore and Indus Valley Ayurvedic Center, Mysore. Presently is working as a professor and head of the Department of PG Studies in Shalya Tantra in SDM Ayurveda Medical College, Udupi and consultant for anorectal diseases at Adarsha Hospital, Kundapura. I welcome you, sir.
I take this opportunity to welcome other dignitaries. First of all, I would like to welcome Dr. Professor A.V. Srinivasan, who is a founder and managing trustee of Sri Paripurna Sanatana Charitable Trust. Dr. Renuka Prasad, Captain Ganesh Karnik, Sri Rameshji, Nirmala Kelvaniji, Dr. Girish Kumarji, Dr. Pallavi Shettyji, and all the members of Swadesh Vijnana Andolan, all the teaching staff and the students of Paripurna Sanatana College, teaching staff and students of Munyal Ayurveda Medical College, and all members and delegates of Dhanvantari Vedike. And this Dhanvantari Vedike itself is the place or the platform on which all these activities are going on. And I congratulate all the members and all the EC members of the Dhanvantari Vedike. And I'm very proud to say that this particular event is being hosted under the title of Azadi Ka Amrit Mahotsav. Thank you, sir. Thank you, Nidal.
Thank you, sir. Sir, you can start the session, sir.
Dr. Rajnish, you can start.
PPT?
No, sir.
Now it's visible? Hello, am I audible?
Yes,
You are
sir. We
audible.
can hear you, sir. Yes, sir. But PPT is not shared, sir. Still, it's not visible.
A minute. I've shared. It's not visible?
No, sir.
Yes, sir. Now we can.
Okay, you can see it. Thank you. So, good evening to everybody. So, first of all, I thank the organizers. So, first of all, I would like to thank the Swadeshi Jagaran Vedike and Munyal Ayurvedic College and Sri Paripurna Sanatana Medical College Hospital and Research Center, Nelmangla, Bangalore, and all the office bearers of these organizations who have taken effort to see to it that this small lecture is recognized so that the students can be benefited out of the sharing. Once again, this session is used to whoever is participating in it. So today, basically, since the topic is a big topic, I would cover only the modern aspects, that is the hemorrhoids and its management, so that whatever the topic is, I would be able to do justice to the topic. So this is my SDM Ayurvedic College Hospital where I work. So Just a minute, the slide is not moving. Okay, so coming to the definition, a simple meaning of hemorrhoids, or what we call as piles. Okay, so by piles basically means a ball or a mass, and hemorrhoids means a condition where there is oozing of the blood. So when we consider the condition, we can take it as a condition wherein there is a dilated vein within the anal canal in the subepithelial region formed by the veins which take the blood from the rectum back into the circulation. Or based on the clinical aspects, we can also consider it as a sliding of the anal cushions, which are sliding downwards due to the abnormal straining or various other reasons. So it's basically a dilated veins inside the anal canal. If you can understand this much at the present, as we start discussing, the things would become more clear. So before we understand the clinical features, etc., we should understand that the hemorrhoids are of two types. One is the internal hemorrhoid and the external hemorrhoid. Am I audible?
Sir, voice is breaking. It is not continue.
Better, can you, Rajneesh ji, can you switch off your video? Only audio can be, I think that will be very clear. Your audio will be then will be clear, I think so, because of the network. Yeah. Please switch off your video and you can start talking now and presentation.
Just a minute. Okay, let me see. I'll be continuing. If somewhere again I'll stop it. As of now, am I audible?
Yes, sir. Now it is clear, sir.
Okay. See, so as I was talking, basically when we classify the hemorrhoids, we can classify it into two types, as the internal hemorrhoids and external hemorrhoids. So if in this figure you are able to see, this is the internal rectal hemorrhoidal plexus and this is the external hemorrhoidal plexus. So these are basically a plexus of veins which are formed from the point of view of draining the blood supply from the anorectal regions. So whenever we are talking about the internal hemorrhoids means they lie within the anal canal and they are within the anal orifice. So this is the anal orifice. The hemorrhoid is lying within the anal orifice, then we would be calling it as internal hemorrhoids. And if you see, this is the mucous membrane. So obviously the internal hemorrhoid will be covered with a mucous membrane which is bright red, or because of the presence of veins it may appear dark or purple in color. And it usually commences at the anorectal ring. This is the anorectal ring and ends at the dentate line. See, this is the dentate line. So somewhere in this region you have the internal hemorrhoidal plexus. So any hemorrhoid or any dilatation which happens in the veins of this plexus, we would be basically calling it as internal hemorrhoids. external hemorrhoids. So external hemorrhoids, it is something which is occurring outside the or below the dentate line and is basically covered by skin. And in certain conditions, you may be able to see that both the internal hemorrhoid as well as external hemorrhoid would be coexisting. Then that is considered as interno-external hemorrhoids. So basically we would be classifying it as a hemorrhoids which is occurring due to the varicosity of internal hemorrhoidal plexus above the dentate line as hemorrhoids, and that which is occurring due to the external hemorrhoidal plexus lying outside the anal canal, we would be classifying it as external hemorrhoids. And a condition where both the internal hemorrhoid and external hemorrhoid coexist, that condition would be called as interno-external hemorrhoids. The external hemorrhoids is associated with certain conditions like dilatation of the veins at the anal verge is seen in persons basically who are following a sedentary lifestyle, and it is seen particularly in people who are having an habit of straining excessively during defecation. So if you see the next slide, I would be able to show you the external hemorrhoid. See, this is typically the internal hemorrhoids here, and this what you are seeing outside the anal canal is nothing but the external hemorrhoid. So it is outside the anal canal. So the peculiarity of the external hemorrhoid which you should remember is that the external hemorrhoid also is associated with a condition where there is a thrombosis of the hemorrhoids. So this is something which you should remember whenever we are discussing about the external hemorrhoids. I will tell you why it is important. See, basically it is a hematoma. That means the blood gets collected in the external hemorrhoids and it gets clotted, resulting in the formation of a thrombosed external hemorrhoid. So this thrombosed external hemorrhoid, the importance is that it appears suddenly and is a very painful condition. See, generally we have to remember that hemorrhoids are painless condition, except this thrombosed hemorrhoid, which is absolutely a condition where it is very painful and it presents as a swelling, okay, a tense painful swelling outside the anal canal. Then we have to understand that it is a case of thrombosed hemorrhoids or a perianal hematoma, which like if you leave it untreated, it may resolve on its own. Sometimes it may suppurate and become an abscess, or sometimes it may get fibrosed, resulting in the formation of a tag. Okay, if you are examining the anal canal, outside the anus you may be able to see tags or skin growths which are nothing but the fibrosed external hemorrhoid. So as I was telling you, the case, this is a case, a diagrammatic representation where this is nothing but the perianal hematoma, or what we call as thrombosed hemorrhoid, which is a tense swelling outside the anal canal, presenting as a tense painful swelling outside the anal canal, which appears suddenly, and many times the patient comes with great pain and expects an immediate result or immediate treatment for it. Apart from the classification of the hemorrhoids into internal hemorrhoids and external hemorrhoids, we also have to understand a classification where the hemorrhoid is classified as primary hemorrhoid and a secondary hemorrhoids. Primary hemorrhoids means, suppose the patient is lying down in lithotomy position and you mark in the form of clock positions, like you mark 6 o'clock, 12 o'clock, 3 o'clock and 9 o'clock. Then if you see hemorrhoids at 3 o'clock, 7 o'clock and 11 o'clock, then that condition is called as primary hemorrhoids. This is related to the branches of the superior hemorrhoidal vessels, which divides on the right side into two and on the left side into one. So those branches are represented in the form of the position 3, 7 and 11. So these hemorrhoids are called as primary hemorrhoids. And suppose hemorrhoid appears elsewhere, like suppose it appears at 4 o'clock, suppose it appears at 9 o'clock, suppose it appears at 2 o'clock position, I am telling you, then we would be calling it as secondary hemorrhoids. So thus we can classify the hemorrhoids apart from internal hemorrhoid and external hemorrhoid. We would also be classifying it as primary hemorrhoids and secondary hemorrhoids. See, this I was telling you, the primary hemorrhoids, the 3 o'clock position, left lateral, 11 o'clock position, right anterior, right posterior. This is the 3 o'clock position, this is the 11 o'clock position, and this is the 7 o'clock position. These hemorrhoids are called as primary hemorrhoids. So if they occur elsewhere, then it is called as secondary hemorrhoids. Apart from that, we also classify the hemorrhoids based on the amount which it prolapses. We classify it into first degree, second degree, third degree and fourth degree. So if you see the description, first degree means hemorrhoid is not appearing outside the anus at all. The patient only complains that there is a bleeding, but you will not be able to visualize any mass outside the anus. Then such hemorrhoids are classified as first degree hemorrhoids. The next classification, as the prolapse of the mass increases, as the severity increases, the hemorrhoids will prolapse out during the act of defecation, and the moment the patient stops the act of defecation, the hemorrhoid reduces or returns back into the anal canal and cannot be visualized outside the anus. Then it is called as second degree hemorrhoids. Now the mass would further increase, and third degree hemorrhoid, during the defecation, the hemorrhoidal mass has become bigger, so it prolapses outside the anal canal, and after the act of defecation, it does not return back on its own or spontaneously and has to be pushed back manually into the anal canal. Then we would be calling it as third degree hemorrhoid. And the last one is a fourth degree hemorrhoids, where the hemorrhoid has become so large and prolapsed so much that during the defecation it comes out, and then in spite of the efforts, it doesn't go back into the anal canal. Then it is called as fourth degree hemorrhoids. If you see here, this is the first degree hemorrhoids. This is the second degree hemorrhoid, a little more bigger in size, which comes out during the act of defecation and goes back. Third degree, it has still more become bigger. During the act of defecation, it will come out and then it has to be pushed back into the anal canal. And fourth degree hemorrhoid is the hemorrhoid which has become so large that after the act of defecation, it remains out, and in spite of the efforts, it would not be able to be pushed back into the anal canal. So thus, at this stage, we have seen that hemorrhoids is basically a dilatation of the veins, varicosity of the veins, the superior hemorrhoidal veins and the inferior hemorrhoidal veins, and we can classify it into internal hemorrhoids, external hemorrhoids. We can classify it into primary hemorrhoids, secondary hemorrhoids, and we can also classify it into degree hemorrhoid, third degree hemorrhoid and fourth degree hemorrhoids. So once we have understood basically what are the types of hemorrhoids, so the next thing is we should understand what is the cause for hemorrhoids. Many times it is hereditary. So okay, in the house the parents or brother or sister is suffering, close relative is suffering, and the patient also gets it. There is a hereditary tendency for the hemorrhoid to run in families. Apart from that, you also have to understand why hemorrhoid is caused. You have to understand the anatomical importance. There is absence of valves in the superior hemorrhoidal plexus. Okay, so the superior hemorrhoidal plexus, which drains into the portal vein, there is no valves in it. So what happens basically when you strain a lot, especially like people who are suffering from constipation, because of the increased intra-abdominal pressure constantly, there is the blood does not return back, but there is a congestion of the blood within the superior hemorrhoidal plexus, making the vein dilated, making the vein varicose. Thus, the patient ends up with a hemorrhoid. Plus, there is an absence of support, good support to the branches or radicals of the superior rectal vein in the subcutaneous tissue. So, since they are not supported well, the anal cushion or the mucosa can easily get prolapsed when a person strains for longer time. Apart from that, excessive straining, as I said, plus a patient having diarrhea where he passes stools large number of times within a short duration, then other conditions like overpurgation, carcinoma of the rectum, pregnancy, portal hypertension, which can all result in congestion of the blood within the veins of the anorectal region, can all result in the causation of hemorrhoids. Apart from that, diet is also very important. People who drink less water, there is a tendency for their stools to become hard. Hence, to pass that, they require to put lot of pressure, which again results in congestion of the veins, which results in hemorrhoids. People who take less roughage in their food, roughage in the food in the sense lack of fiber, lack of not taking enough quantity of raw vegetables, fruits. So lack of fiber in the diet automatically makes the stool hard, and as a result of which the patient will have to put a lot of pressure to pass the stools, resulting in overstraining, resulting in congestion of the blood within the veins, resulting in varicosity of the veins, and thus the patient starts suffering from hemorrhoids. So, after we understood the etiology, next, how do we understand the condition? Okay. So, basically, even before we do any form of investigative procedure, one of the important way to diagnose a condition is the clinical presentation. And in hemorrhoids, as the name itself suggests, hem is blood, rus is flowing. So hemorrhoids is a condition where there is flowing of blood. So obviously the first feature which the patient would present is bleeding. So this is a very important condition called as splash in the pan. That means to say the patient goes to pass the stools, and along with the stool there is a passage of large quantity of blood which is bright red, painless. So it splashes in the pan. So the typical presentation of bleeding in the hemorrhoids is called as splash in the pan. This would be different when the bleeding is from the colon. This would be different when the bleeding is, for example, in a case of fissure in ano. So therefore, in hemorrhoids, you have to understand that the bleeding is splash in the pan. So as soon as the patient sees, see, there are very few symptoms. There are few symptoms which makes the patient come running to the doctor. One is bleeding when he sees blood, and second is when there is pain. These are two things. So here what happens is, as soon as he passes the stools and he sees such large quantity of blood going into the pan, he obviously becomes anxious, frightened, and he comes to you for the treatment. So bleeding is the first symptom which draws the attention of the patient and which makes the patient seek the treatment from a physician. Gradually, as the condition increases or as the condition worsens, there can be a mass per annum. Now, apart from bleeding or without bleeding, the patient may start presenting, or he may come to you saying that during the defecation or after the defecation, he feels a mass in the anal region outside the anus while washing. So this is the next complaint. So as I already said, depending upon the severity, depending upon the size with which it prolapses outside the anus, we can classify it into as first degree hemorrhoid, second degree hemorrhoid, third degree hemorrhoid, and fourth degree hemorrhoid. So this classification is very important, which is classified based on the patient's complaint. If the patient says he is not able to see any mass, the only complaint, obvious complaint is bleeding, we would be classifying it as first degree. He says that during the defecation I am able to feel a mass there, but as I finish the act of defecation it disappears, then it would be second degree. Third degree, when he says after the defecation I am able to feel a mass but I push it and it goes back into the anal canal, obviously it's a third degree. And if he says that after defecation I am feeling a mass outside the anus, then it is fourth degree. So this clinical understanding of the degree, first degree, second degree, third degree, fourth degree, is a very important thing, because it helps you to decide the mode of or the modality of treatment which you want to adopt, whether you want to give medication, whether you want to go in for some other minimally invasive surgical procedure, or whether you want to go for a surgical procedure. Plus, to help the patient to understand the prognosis, understanding of the degree of hemorrhoids is very important. So bleeding is an important clinical feature which helps you to understand about the diagnosis of the hemorrhoids. Second, the presence of a mass near the anus is also a very important clinical feature which will help you to diagnose the condition of hemorrhoids. Next very important condition is pain. You always have to remember that pain is not a characteristic feature of this disease. So a patient complaining of pain during defecation, generally the diagnosis is not a hemorrhoid, the diagnosis goes towards fissure in ano. I have not told you about fissure in ano. Most of you may be knowing it, or people who don't know. Fissure means a tear. Whenever a person tries to pass a hard stool, whenever he strains unnecessary excessively during the act of defecation, the soft mucous membrane at the edge of the anal canal tears, resulting in a very painful condition. And there is also a small quantity of bleeding. So pain during defecation, your diagnosis goes towards fissure in ano rather than hemorrhoid. Bleeding, splash in the pan, or drops of blood falling during the defecation, the diagnosis goes towards hemorrhoids. Whereas bleeding just on the stool in the form of a line, the diagnosis goes towards fissure in ano. So why I need to tell this is, when a patient comes to the anorectal clinic complaining of pain during defecation, he only says that I have a Mulavyadi or I have a problem of area. So immediately we think that it is hemorrhoids. So pain is not a characteristic feature of hemorrhoids. Well, but you should also remember that there is one condition called as thrombosed hemorrhoid, which I showed you already, which when present can make the hemorrhoid a painful condition. So when a patient comes anal canal, and if you are able to see a tense, hard, painful swelling just near the anus, then it can be a thrombosed hemorrhoid. It is painful. If not, generally hemorrhoids is not associated with pain. So after bleeding, after the prolapse, pain, the next important complaint which the patient may say is mucus discharge. Mucus discharge is not a characteristic feature in first degree and second degree hemorrhoids. But third degree hemorrhoids and fourth degree hemorrhoids, as I have already told you, the internal hemorrhoid is basically covered with mucous membrane. So whenever the hemorrhoidal mass prolapses outside the anus, the mucous membrane which is secreting the mucus makes the whole area around the anus moist, as a result of which the person feels a lot of itching in that area, which is called as pruritus ani. So mucus discharge is not a characteristic feature in first degree and second degree hemorrhoids, but the moment it starts prolapsing outside the anus, third and fourth degree hemorrhoid, because there is going to be an excessive mucus discharge in that area, the whole area around the anus becomes soggy, becomes soiled with mucus, and because of which the patient now starts complaining of pruritus ani. So bleeding, then prolapse of the mass, then pain, then mucus discharge. And last but not the least, the another important feature is anemia. Sometimes you send the patient for general blood checkup and you see an low HB, and when you properly interrogate the patient, you will see that the patient is losing lot of blood through the defecation in the form of the diagnosis of hemorrhoids. So many times the hemorrhoids, the bleeding is so much and the patient has not adequately taken care that he ends up with anemia. So anemia is also another important feature, clinical feature, which can help you to diagnose that probably this is a condition of hemorrhoids. So just a review, the clinical features, basically it would be a bleeding in the form of drops during defecation or a splash in the pan, and the pain not a characteristic feature of hemorrhoid, only a characteristic feature of a complicated hemorrhoid called as thrombosed hemorrhoid. Then depending upon the severity, the patient may complain of a mass in the anal region. He may complain of mucus discharge, and in long standing conditions he may also complain of anemia. So based on these clinical features, you can get an idea that maybe the person is suffering from hemorrhoids. So once you have done this, the next is the stage of investigation. So the most important examination is the digital rectal examination. We do digital rectal examination, and this is a examination which you have to learn with lot of repeated examination or by your experience. Why? Because hemorrhoids is not palpable when you do a digital rectal examination. That is, you put your gloved lubricated index finger into the anal canal. Second and third degree hemorrhoids can be seen when the patient strains, you will be able to see. But when you do a digital rectal examination, basically you are not able to palpate anything. So hemorrhoids is not felt, hemorrhoids is basically visualized. So you make the patient lie down in a lithotomy position, ask him to strain. Second and third degree can be seen only when the patient strains, first degree cannot be seen, and fourth degree is prolapsed completely outside the anus. The moment he lies down, you will be able to see. So once you have seen this, you do a rectal examination. 4th degree you don't have to do. Other degrees, when you do a digital examination, until and unless you are very experienced, you will not be able to feel the mass. Then how do you confirm it? So to confirm the presence of the hemorrhoid, the best examination is proctoscopy. So all of you have seen the proctoscopes in any of the Shalya OPD. So you can the surgical OPDs, so well lubricated proctoscope, when you gently insert into the anal canal. So as seen in this figure, you will be able to see the prolapse of the hemorrhoidal mass. Okay, it may be at 3, 7 or 11 o'clock positions. Then we would be calling it as primary internal hemorrhoids. And if it is prolapsing from other position, then we would be calling it as secondary internal hemorrhoids. So in a clinic, in a clinical setup, OPD setup, based on the inspection, based on digital examination, based on proctoscopic examination, you will be able to confirm the diagnosis as whether it is a first degree, second degree, third degree, fourth degree internal hemorrhoids, and whether it is a primary hemorrhoid and what is the position of the hemorrhoids. Digital rectal examination here is very important. Why? Because there are certain associated diseases which can result in hemorrhoids or can result in bleeding per rectum. So when you do the per rectal examination, though you may not be able to feel the mass, but you essentially can rule out certain other conditions which may mimic hemorrhoids. For example, a patient comes to you with bleeding per rectum. Just by taking history, if you make a diagnosis that it's hemorrhoid and start the treatment, And if the condition is a case of CA of rectum, where the complaint is similar, the patient passes blood during defecation, so the diagnosis would be very wrong, and it would be a crime in not doing a perrectal examination before starting the medication. So any patient coming to you with perrectal bleeding, if it is not painful and if the patient consents, it is always mandatory that you do a digital rectal examination and check for the presence of any masses in the rectum or in the anorectal region, to be precise. And once you confirm that there are no such masses, it is a simple case. Confirm with proctoscopy, if required sigmoidoscopy, if required colonoscopy. It depends upon the facility available, it depends upon the skill of the examining surgeon. And after you have made a diagnosis that whether it is a first degree hemorrhoid, second degree hemorrhoid, third degree hemorrhoid, whether it's an internal hemorrhoid, external hemorrhoid, then only think of starting any form of treatment. So basically, you have to diagnose clinically, confirm it by visual examination, then by digital rectal examination, try to rule out other conditions which may mimic similar clinical presentations, then do a proctoscopic examination, confirm your diagnosis. Further, if you want to confirm other pathologies which might have caused this condition, you can also send him for a colonoscopy. So thus, based on clinical aspects, based on the investigative aspects, you confirm that it is a hemorrhoid. And when you write the diagnosis of hemorrhoids, a correct surgeon or a person who has done the correct diagnosis, it is always nice when the hemorrhoids is associated with correct terminologies in the form of whether it's an internal hemorrhoid, whether it is an external hemorrhoid, what is the position of hemorrhoid, whether it is 3 o'clock, 7 o'clock or 11 o'clock, and what is the degree. So if you are able to write all these in the diagnosis, it shows that you are a complete surgeon or you are a complete physician and you have done a proper diagnosis of the condition, rather than just in the prescription writing it as hemorrhoids. If you write all these, so it shows your clinical skill or clinical expertise. So once you have done all these, the next most important thing is to understand the complication of the hemorrhoid. Well, you have done the diagnosis, everything. Now the patient would surely ask you whether should I undergo the treatment immediately, or can I postpone the treatment by doing certain diet and home medication, home remedies. Then you should be able to tell the patient what are the complications which may surface, which may manifest. So bleeding is a very important sign, as I have already told you. When the bleeding is substantial, when the bleeding is happening over a long period of time, the patient would surely end up with anemia. So this is something which you have to tell the patient. So if this bleeding continues, you will surely end up with anemia, which has its own complications. So the choice of the treatment is yours. This is one thing which I give a lot of importance, especially the students who are hearing this lecture. The moment a patient comes to us with bleeding per rectum, immediately the student says, sir, it's a case of hemorrhoids. All bleeding per rectum need not be a case of diagnosis, need not be a case of hemorrhoids. So this is something which you have to fix it in your mind. All cases of bleeding per rectum are not hemorrhoids. You need to do a thorough examination before you decide it as hemorrhoids. Prescription C. The clinic has no place to even examine a patient. It's so small clinic. The moment the patient says bleeding per rectum, they start off the prescription for hemorrhoids or arches, and later when they come to us and we examine it, it's a case of CA of rectum. Lost in laying the treatment required for CA. So therefore, any bleeding per rectum, don't diagnose or don't think or don't decide that it's a case of hemorrhoids. So there are a lot of other conditions where there can be a bleeding per rectum. I would be tell few conditions like hemorrhoids. As we all know, it shows itself as bleeding per rectum, fissure in ano, polyps in children. Polyp is a main reason for bleeding. Many times they make a diagnosis even in children as hemorrhoids, and most of you know hemorrhoids is a condition which happens over a period of years due to a lifestyle problem. So you cannot have a hemorrhoid in a child. So bleeding per rectum in a child is more, the diagnosis is towards polyps. Then bleeding, think of ulcerative colitis, think of amoebic colitis. Very important, think of carcinoma. Think of carcinoma of rectum, carcinoma of colon. Think of diverticulitis. Think of intussusception. Think of mesenteric ischemia. So there are so many conditions. I have just enumerated few of the conditions where the final clinical presentation is bleeding per rectum. So this slide is basically, I have showed you to tell you that bleeding per rectum, don't always concretize it, don't always diagnose it as hemorrhoids and start whatever medication. Think of all these conditions, rule out all these conditions. Once you have ruled out that, fine, then confirm it as hemorrhoids and then start the treatment. Whatever modality of treatment you put, until and unless the diagnosis is perfect, the treatment would not be successful, or you cannot claim yourself as a doctor who is giving a correct prescription. So the diagnosis is important, rule out the other possibilities and then start your medication for hemorrhoids. So apart from bleeding, the other complication which the patient can anytime end up is thrombosis. So the patient has a hard stool, maybe he has traveled, maybe he has consumed excessive non-vegetarian food which lacks fiber. So this is a complication which can occur. Sometimes in a case of 3rd degree and 4th degree hemorrhoid, as the mass passes outside the anus, the external sphincters may tighten around the prolapsed hemorrhoidal mass, resulting in a condition called as strangulation. So the hemorrhoids may get strangulated. And in a very bad condition, it may also result in gangrene, resulting in portal pyemia. Okay, so the infection may enter into the portal circulation, resulting in a very bad complication called as portal pyemia. Or if everything is good, no gangrene occurs, there is a fibrosis and it subsides, or it may suppurate, resulting in the formation of an abscess. So strangulation, thrombosis, bleeding resulting in anemia, thrombosis, strangulation, ulceration, gangrene, or fibrosis. So these are all the complications which can occur in a case of hemorrhoids, which as a doctor you should know and you should be able to convey to the patient so that they understand regarding the seriousness of the condition. Coming to the treatment, as is the case, you always try with non-operative treatments and only then go into the operative treatments. So the easiest non-surgical treatment is to advise the patient to have a sitz bath. As the name itself suggests, the patient is made to sit in a tub filled with warm water, bearable warm water. If required, you can add little Dettol or betadine, or just plain warm water is also sufficient. Salt etc. is not advisable because it can irritate the area there, resulting in further complications. So just ask him to sit in a warm tub. So it relaxes the sphincters there. It reduces the edema. Basically, it reduces the pain and it also helps in healing of any ulcers. So basically, sitz bath plays a very important role. Ask him to sit for about 15 to 20 minutes twice daily after the act of defecation. This gives a lot of relief to the patient. Then there are a lot of ointments available which you can advise the patient to apply to the area, which basically helps to reduce the pain, helps to reduce the swelling, prevents bleeding, reduces the chances of ulceration. There are large number of ointments available, both Ayurvedic ointments, the allopathic ointments, available which can help you in this regard. And if the patient is suffering from constipation, obviously you will have to give laxatives. There are different types of medications available. Some are purgatives, some are laxatives. So when a patient is suffering from hemorrhoids, purgative should be avoided. Go for laxative. Go for bulk producing laxatives. The best drug would be isabgol. So isabgol is a husk, it's a fiber. When the patient consumes it, it mixes with the stool, makes the stool soft, makes the stool bulky, as a result of which it passes out easily without causing pressure on the veins, and as a result of which there is no congestion, there is no chance or there is reduced chance for formation of hemorrhoids. Suppose the 3rd degree hemorrhoid, 4th degree hemorrhoid has got infected, sitz bath and other medications are not helping, then certain antibiotics and anti-inflammatory drugs may be required to give relief to the patient. Then this is a procedure which has to be strictly done by a surgeon, which is called as Lord's dilatation. So under anesthesia, so the sphincters are dilated by a technique. Okay, so people who have, you have to learn it. It's not something which can be done by everyone and everywhere, because as you are stretching the sphincters, you can lose the patient, because the patient, because of the pain, can go into vasovagal shock and you may also lose the patient. So until and unless you have trained in this, kindly don't do this. So you are basically stretching the anal sphincter so that the congestion is reduced and the pile mass which was prolapsed out goes back into the anal canal, and the patient to a certain extent gets relieved of his complaints. So Lord's dilatation, after you have been trained in that, you can do it. Apart from this, the minimal invasive surgical treatments, you have what is called as injection therapy or sclerotherapy, where 5% phenol in almond oil with 140 milligrams of menthol to make a 30 ml solution, you get it as Albright solution. You can inject it into the mucosa, submucosa. Okay, it is a relatively painless, quick, less complicated procedure, especially in case of 1st degree hemorrhoid where bleeding is the main complaint. But you cannot use it in 2nd degree, you cannot use it in 3rd degree or 4th degree hemorrhoids where prolapse is the main complaint. So if you can see this, the injection is being given into the submucosa, so it creates a sclerosis in this area. So the mass also reduces and the prolapse, it sticks, or fibrosis occurs and it sticks on to the underlying muscles, as a result of which the bleeding also stops. The chances of prolapse also would be removed. Next, you have a method called as rubber bandation. If you can see here, with a barren band applicator, you can fix the rubber band to the base of the pile mass. So ideal for treating large 1st and 2nd degree hemorrhoids, the band should occlude the base of the hemorrhoid at least 1 centimeter above the dentate line. The area above the dentate line is not painful, so you have to apply the rubber band above the dentate line. But sometimes it is associated with sloughing, associated with slipping of the rubber band, resulting in pain and hemorrhage. So this is something which, until and unless you are trained, never to adopt it. Next is cryosurgery. So there is a procedure called as cryotherapy, where liquid nitrogen at a temperature of about minus 130 degrees, 196 degrees centigrade is exposed to the base of the hemorrhoids for about 3 minutes. See, this causes freezing of tissues of the hemorrhoids and it leads to necrosis and the hemorrhoidal mass gets separated. And the best thing is, this procedure does not create pain. So cryotherapy is also a therapy which can be done by a trained surgeon. But there is a problem that there is profuse watery discharge which starts within 3 hours and continues for about 2 to 4 weeks, and the healing will require about 4 to 6 weeks. The last but not the least procedure, the last final procedure is hemorrhoidectomy, especially conditions where the hemorrhoid is big, like 3rd-degree hemorrhoid, 4th-degree hemorrhoid, where you can't do the conservative management, where you can't do the sclerotherapy, where you cannot do rubber band ligation, then the only option available is hemorrhoidectomy. Okay, generally it is associated with lot of post-operative pain, but still this is the only option available. So it can be a hemorrhoidectomy, after which you leave the wound open, then it is called as open hemorrhoidectomy, or you can do a hemorrhoidectomy and then you can suture the wound, then it is called as closed hemorrhoidectomy. You have staplers to do the hemorrhoidectomy, then it is called as stapled hemorrhoidectomy. So thus either it can be managed conservatively with sitz bath, local applicants, laxatives, certain medications, if required antibiotics, analgesics, or you can go for sclerotherapy, you can go for rubber band ligation, you can go for cryotherapy. And still if the degree is 3rd and 4th degree and other treatments fail, then the procedure is hemorrhoidectomy, where it can be a surgeon can do a closed hemorrhoidectomy, open hemorrhoidectomy, stapled hemorrhoidectomy, or any other forms of hemorrhoidectomy. So thus, so in today's lecture, ending it, summarizing, we have understood what do we understand by the word hemorrhoids or piles. We have understood the types of hemorrhoids as internal, external, 1st degree, 2nd degree, 3rd degree, 4th degree, primary hemorrhoid, secondary hemorrhoid. We have understood what are the etiological factors. We have also understood what are the clinical features to diagnose the hemorrhoid, what are the proctoscopic and other examination techniques required to diagnose it. We have understood what are the complications if we don't treat it, how do you treat it conservatively, how do you treat it minimally surgical techniques and by surgical procedures. So I would like to end here. I have given a very brief review of hemorrhoids, considering that the time schedule, whatever I have given information was of some use to all of you. I would like to wind up my lecture of today's. Thank you.
Thank you so much, sir. It was really informative. Uh, Sir, I will ask you the questions from the chat box. So there is a question regarding best Ayurvedic herbs for piles or hemorrhoid treatment.
There are a lot of medications. See, simple, you have Taja, you have Balataka, as I said, you have Isabgol. If there is any injuries associated, you have Jatyadi Taila, you have Yashti Madhu Taila. Okay, there are Surana, okay, all these radish, okay, you have Takra. So these are all these drugs which can be advised to the patient apart from medicines to help to overcome the hemorrhoids. Basically try to set right his lifestyle, set right his act of defecation without constipation, and if he has a habit of straining, ask him to overcome it. Then there are various medicines available to treat him.
Sir, what are the factors we have to consider if patient has diabetes or hypertension associated with it?
I'm not able
Hello.
to hear.
Yes, sir. There is a question like if the patient who is suffering with hemorrhoids with any diabetes or a hypertension condition, so what can be changed in the treatment according to that?
I didn't get.
Hello, can you hear me, sir?
Yeah, now I can hear you.
Yes, sir. Sir, there is a question regarding if the patient with hemorrhoids has hypertension or a diabetes, what can we change in the treatment principle for the treatment? What should we consider, sir, at that? Can you hear me, sir?
Can hear you.
Not able to hear you, sir.
Sorry, doctor, I can't hear you. Neither I am able to see the questions to clear it.
Okay, sir. Sir, can you see the question?
I still can't hear anyone. Okay, which is the best treatment? I can see one question here, laser or open hemorrhoidectomy. You can always go in for the laser. Okay, when the hemorrhoids are bigger, maybe then you cannot try laser. It's better you go in for a open hemorrhoidectomy. This is the only question I can see here in the chat box. Haritaki is most prescribed drug in piles patient. What is your opinion on the drug? Obviously, it's the best drug which you can advise, a very good drug. So, Haritaki, Mrudu Virechaka. So, it basically helps in easy defecation, easy bowel movement. Thus, it would help in reducing the congestion of the blood in the hemorrhoidal veins and thus help in reducing the size of the drug. So, it is quite obviously a good drug which you can prescribe. A hypertensive patient with hemorrhoid, what we should prescribe to clear the constipation? See, you can go in for simple laxatives. The easiest I would advise is isabgol. You can give. Don't go in for much of irritant purgatives like erandathaila or senna, which can create problems. Go in for stool softeners. Anything which has isabgol, which has aragvada or trivrut leha, manibhadraguda, this would be very useful in treating the patients. Sir, then laser Ksharakarma is also best. Yeah, Ksharakarma is a very good treatment. See, I am not covered much of Ayurvedic aspect here. So Ksharakarma for a hemorrhoid is the best treatment today. You don't even have to do hemorrhoidectomy. Even in first degree, second degree and third degree, you can manage very well with Kshara. Kshara is without much of complications. Ksharakarma is a wonderful treatment for the management of hemorrhoids. So fourth degree, well, you will have to go for surgery, but for the first 3 degrees, Ksharakarma is one of the best surgical procedure which has been given to the science by Ayurvedic surgeons. Yeah, how to differentiate between rectal prolapse and 4th-degree hemorrhoids? See, hemorrhoids basically is coming out as in the form of masses. The rectal prolapse comes out in one mass all throughout the circumference of the anus, whereas hemorrhoids, as we have already learnt, it is the radical of the veins. So you get it at different masses, 3 o'clock, 7 o'clock, 11 o'clock. So it is in the form of individual masses, whereas the rectal prolapse comes out in one particular mass, and rectal mass which is prolapsing is pinkish red in color, hemorrhoids is bluish red in color, which will also help you to understand whether it's a hemorrhoid or a rectal prolapse. Ksharakharma is done by lot of people in Karnataka and elsewhere. So Ksharakharma is not a medicine which can be given. Ksharakharma has to be done by a Ayurvedic surgeon in hospital. So it cannot be done even in a OPD basis. It has to be done in the hospital. As the bleeding is from vein, how can it be bright red in color? See, the radicals have both the arterial component and the venous component. So the bleeding, when it happens, can be a bright red in color. Which one is best, rubber band ligation or Ksharasutra ligation? Both have similar complication, that if it is below the dentate line, it can become a very painful procedure. Compared to the Ksharasutra ligation, Ksharakharma is less complicated with greater results. So at any given moment of time, preference to Ksharakharma is better than Ksharasutra ligations. Everybody has their own opinion about this, but I would be speaking based on my clinical experience, that I would prefer Ksharakharma over Ksharasutra ligation. What is your message for people who go to piles doctor, who takes out along with roots of piles? See, this is some question which I really don't understand, because there are people who go to a doctor and he just does something and removes a mass and shows it to the patient, saying that he has excised the mass. And I have seen such patients coming to me within 1 year or 2 years again with a second degree and third degree hemorrhoid. So I really don't know what they are removing. So rather than going to these piles doctor, if qualified, I have no issues, but if they are not qualified, it is not advisable to go to such people. There are so many Ayurvedic doctors qualified from very good institutions. Go to them, take the right treatment. Which Pratisarniya Kshara would be best for Ksharakharma? Pratisarniya Kshara, lots of ingredients go into it. The commonest Pratisarniya Kshara is with Apamarga. To Apamarga, you know the Ksharakharma procedure. We do a Tikshna Kshara by adding limestone, Chitraka, Vacha, etc. and making it Tikshna. So such Pratisarniya Kshara is better for Ksharakharma. With respect to vegetable as medicine, Mulika is having good results. Yeah, Mulaka, Surana, these are very nice drugs which can be tried for the treatment of the hemorrhoids. I don't see any more questions here. If there are any questions, you can tell me. So if the questions are over, do I can stop
All
it
the
here?
questions are
Or
over,
is there
sir.
Dr. Aarti or
Dr. Meghana, Dr. Aarti, can you
Okay.
call Dr. Meghana for a vote of
Yes,
thanks?
yes, sir. Thank you so much, sir. I think sir has covered almost all the questions. Now I will call Dr. Meghna, Assistant Professor in Department of Rashastra and Vaishesha Kalpana, for the vote of thanks. Thank you.
Very good evening to everyone. It's my privilege to deliver a vote of thanks on this webinar. Firstly, I would like to extend my gratitude to our speaker of the day, Dr. Rajneesh V. Giri, Professor and HOD, Department of Shalya Tantra, SDM College of Ayurveda, Udupi, for all the valuable information he had shared with us on the topic. Thank you, sir, for giving a detailed description on the definition, etiology, classification, clinical features, examination, and other management of hemorrhoids. On the behalf of entire organizing team, I wholeheartedly extend my thanks to you, sir. Next, I would like to thank Swadeshi Vignan Andolana Karnataka and organizers of Dhanvantari Vedike for organizing such an informative webinar. I also thank Sri Paripurna Sanatana Ayurveda Medical College, Hospital and Research Center and Munyal Institute of Ayurveda Medical Sciences for collaborating with SVAK and making this event successful. I would also extend my heartfelt thanks to Ganesh Karnik sir, State President SVAK, Dr. Sri Renuka Prasad, Working President SVAK, and Professor Dr. A.V. Srinivasan Swamiji, Founder and Managing Trustee, Sri Paripurna Sanatana Charitable Trust, and also Sri Ramesh H., Dr. Nirmala Kelmani, Dr. Girish Kumar, Dr. Pallavi Shetty, and all other organizing team who have directly and indirectly involved in this webinar and making it a grand success. And lastly, most importantly, I must thank all the BMS students, faculty, Ayurveda doctors, and all other participants for taking part in this webinar and making it a grand success. Thank you, one and all.
Also, we would like to thank our Dr. Shripati Acharya ji, who is Dean of Munyal Institute of Ayurvedic College and also our convener of Dhanvantari Vedike of Swadeshi Vijnanadana, Karnataka, who has been mentoring for all this lecture series. Dr. Shripati Acharya ji, thank you very much.
Yes, thank you, sir. Thank you so much.